My topic today assigned is liver diseases in Chinese, a perspective from a practicing hepatologist. I think I'm a clinician, so how we use the compounds and what we really need. Well, Hong Kong was returned to the mainland China in sovereignties in 1997, and I set up the Humanity and Health Medical Group in 2008 to 9 after I resigned from the university, so that I have more time to work on what I really want to do based on one country and two systems. The ideas behind is how we can expand our service from just serving 7.2 million Chinese in Hong Kong, but to the 1.36 billion Chinese in mainland China and beyond. And hopefully we would include Taiwan very soon to our scenario. The transit between Hong Kong and China each day across the border approximates 500,000 people. So a lot of people come to Hong Kong from mainland China with a 1-week visa to do all the business and also to seek medical advice. I decided at that time to build up our collaborations in intensive manner with Beijing 302 Hospital, which is the largest hospital for liver diseases, seeing around 400 hepatitis C patients per day, 2,550 patients on hepatitis B per day. And we treat more than 5,000 liver cancer per year. Well, China is huge. Everybody rushed to Beijing to seek further advice in medical treatment. And the medical tourism from outside Beijing, from mainland China, is around, the official figures is around 700,000 per day. So everybody goes to Beijing, and I think that working with them would give us an opportunity to serve our countries in a more effective manner from a hepatologist perspective of view. So after working with them and well, with intense communications, we work out the protocols and structures of setting up the first of its kind Beijing 302 Hong Kong Humanity and Health Hepatitis C Diagnosis and Treatment Center. Actually, was set up before the availabilities of sulfosylvirs and the DAAs. At that time, we were still using interferon. But to date, using these systems, seeing patients, recruiting them from Beijing 302 hospitals, and having the patients treated in Hong Kong and in a dual systems, under one country and two systems dogma, we have treated more than 3,000 hepatitis C patients with pan-oral DAAs, mostly provided by the Gilead Science. We also set up the Institute of Translational Hepatology with a few colleagues. This picture was taken actually the last week in Beijing when we were there. We are asked by the Department of Science and Technologies to take this photo because we was just awarded the research grants for science and innovations in hepatitis, amounting to the 100 million yuan. So we have built up a team to understand what it is about in terms of our hepatitis, translational hepatologies, how we can apply to patients, predictors, why patients respond, and how can we improve therapies based on the inventions from companies like Gilead, MSD, Bristol Myers, GSK, etc. Our groups, Humanity and Health Medical Center, medical groups, was the first non-public institute ever awarded the National Science and Technology Program second-class award by the Mr. Xi Jinping, the President of China, in 2015. So I think that we have done some work with good communications with our China colleagues. And one of them is illustrated by our recent observations on HBV reactivations after DAAs treatments. Actually presents some of the data 2 years ago at the Hep DART. Suffice to say is that a lot of our chronic hepatitis C patients treated with pan-oral DAAs, as different from those patients in the Western world where the registration trial was conducted. A lot of them is actually co-infected with hepatitis B, being surface antigen positive. This is not surprising because we are a big country with a lot of chronic hepatitis B. It's endemic. So co-infection is not uncommon, and we are among the first groups to observe severe hepatitis due to HB reactivations when these patients were treated with DAAs. These are the 3 cases, and I want to point out that the most severe cases are the ones treated with the Procurement, which includes protease inhibitors. And I understand that in the other talks in during these meetings, some of these issues will be discussed. And with our work, well, we are glad that the U.S. draw the attention of the U.S. FDA and the black box warnings was initiated. Because all the studies on hepatitis C, surface antigen positives was actually an exclusion criteria. But if the DAAs comes to our countries, China, a lot of them are co-infected. And if that is left undetected, some of these patients would suffer unnecessarily from hepatitis due to HBV reactivations while being cured for hepatitis C. And I think this is very timely. And our further work indicates that the DAAs-based therapies, they cause HB reactivations, but this types of reactivations, the timing is different from that with interferon-based therapies. Probably because of the suppressions of the hepatitis C is actually removed the immune controls on the hepatitis B, and really and this leads to enhanced HB reactivations. And in some of these patients, this further leads to hepatitis due to HBV reactivations. But it is simple. If we can prevent, and it is totally preventable, we should identify those patients who are also surface antigen positive. For hepatitis C patients treated with pan-oral DAAs, and then either we monitor them closely or even just to give nucleoside analogs as a preemptive therapy, and this is completely preventable. Now, having said that, I would like to turn your attentions to some of the issues I think related to the practice of hepatology in China. In the past 5 years, our medical group spent a lot of time working actually in Beijing, seeing patients. As I have alluded, we have seen treated and cured more than 3,000 Chinese subjects in mainland China with pan-oral DAAs. And currently, our centers are seeing around 10,000 in Hong Kong, seeing around 10,000 chronic hepatitis B patients being treated continuously with the nucleoside or nucleotide analogs in terms of tenofovir and recently the TAF and entecavir. So first of all, what is the disease burdens? And then I would like to illustrate some of the problems with hepatitis C we are still facing and what we need for the chronic hepatitis B. Well, China is a big country for liver diseases. In that sense, unfortunately, in the recent few years, despite all the developments of understandings in hepatitis B, hepatitis C, and the other liver diseases, so we are still seeing an increased death related to chronic liver diseases in China. So, as you can see over here, the cause of chronic liver disease deaths mainly related to liver development of liver cancers is still increasing despite all the effective measures and vaccinations. Though we are seeing a slight drops in those related to chronic hepatitis B, but that is picked up by other chronic liver diseases such as chronic hepatitis C and also alcoholic and non-alcoholic fatty liver. We are seeing less hepatitis B infected subjects in China, and this figures is based on our publications recently, the Lancet Infectious Disease in collaborations with Professor Hou Jingling's groups in the Nanfang Hospitals, Guangzhou, who was the president of PASOS 2 years ago. And as you can see here, the surface antigen positivity rates has decreased. So with the effective implementations of the vaccinations programs in China. And we are starting to also to see some impacts of these reductions in surface antigen positivities in terms of the development of liver cancers due to hepatitis B in our country. But unfortunately, this is actually overwhelmed by the increased numbers of hepatitis C cases in China. This figure shows the reported incidence of hepatitis C in China. As you can see here, there's a dramatic increase since 2003 to 2012. And in fact, in 2016, the most recent figures, it has reached more than 250,000 hepatitis C patients reported. Those are seen in the hospitals due to hepatitis, liver failures, or liver cancers. Another of the issues which is emerging in our regions is related to the development of NASH or NAFR. With the improvements of the economic status and westernizations of the eating habits, with all the McDonald's and so on in our countries, with all the Kobe beef coming into our countries, and in general, the population is increasing in obesity. And also this comes with an increase in the incidence of type 2 diabetes and its related non-alcoholic fatty liver diseases. These figures, I borrowed this from Professor Jia Jidong from Beijing, and you can see here over the past 10 years, there is an increase in incidence of NASH and also alcoholic liver diseases. So in a sense, it's overtaking chronic hepatitis B and maintaining the momentum of increase in deaths related to liver diseases in our country. So this, I think, from a hepatologist's point of view, we have a lot to do. Now I want to turn to your attention about hepatitis C and where the science meets public health. So based on the editorials I wrote a couple of months ago in the Lancet GH. We all know that we have the very potent pan-oral DAAs approaching 100% SVRs demonstrated in the clinical trials and also validated in real-life studies. But the major barriers to chronic hepatitis C, the eliminations in our countries, is mainly based on the lack of diagnosis, requirements of viral assessments and the genotypings until recently, and also the treatment deliveries. Not until recently, in April 2017, interferon is still the only therapies approved in mainland China, and it is not totally reimbursed. The out-of-pocket cash ranges from the U.S. $2,500,000 to $10,000. So not a lot of patients really can afford, and if it is not reimbursed, and not a lot of places have the interferon reimbursed. It is not a very good drug with side effects, and the efficacy nowadays is not acceptable. Unfortunately, China is not listed on the voluntary license as illustrated by Dr. John Martin just then, and so we do not have the license to make the pan-oral direct antivirals for hepatitis C. And in China, we have an estimated population of close to 30 million chronic hepatitis C patients. So not until recently, in the past few years, with all the DAAs, with the licensings to other countries like India's, generics of DAAs has been made available through the black market channels. In fact, in our experience in Beijing's 302 hospitals, advertisements is everywhere. They do the direct deliveries like the eBay things. And I think this is pretty unsafe, but there is no choice. Because the cost of having generic DAAs is only 1% of those costs listed in U.S. a couple of years ago. So I understand the price in the U.S. and Europe is also dropping nowadays, but at that time it's 100 times more expensive. So it's actually instilled a lot of activities and transportations and arrangements of all the generics flooding into the mainland China. And these are the few manufacturers of the generics compounds. Unfortunately, with the black market, there is not regulated. And sometimes we see the serious side effects, not because of the drugs were properly made, but there are other companies of the generics, which cause a lot of problems because this is totally chaotic. Recently, there is a papers published in China, in Henan, where they see also a lot of hepatitis C patients. They actually report the use of generics DAAs from India. Produced by Nanacos. It's one of the who has licensing agreements with Gilead Sciences, and it shows that the generics DAAs is equally effective as in Chinese population with chronic hepatitis C infections. Having said that, well, we have a lot of chronic hepatitis C patients. They want treatments. They know pan-oral DAAs will be very effective. But until the 2016, the less than 1% of them were being treated. And that includes the use of the generics through the black markets and illegal channels. Very few of them actually travels to India. So the drugs is actually imported through various channels, and this is also made in places like Bangladesh, Vietnam, and so on, Laos. So the qualities of such is not being regulated. And I think this is might do more harms than benefits in some of our patients. And I have seen patients who suffer from renal failures, who requires dialysis, and eventually died of renal diseases because of the use of these so-called generics, which is not regulated as in India. The good news is pan-oral DAAs is now being made available in China. And so we have the Sovaldi's, the FD3Ds, and also the BMS dual therapies. And the cost is negotiated by the government, and I think it comes to the $9,000, which is 1/10 of those in the US. I'm not sure whether it would attract American citizens to come to China to receive treatments, because now it is 1/10 cheaper in China. And I think this includes some of the tourisms and Beijing duck too, if that is the case. Now, another aspect of how we look at the problems is, are we really over-treating Chinese with chronic hepatitis C? Now, we know that Chinese have certain different characteristics in terms of immunogenetics and so on as compared to the Caucasians, as the Caucasians compares to the African Americans. So based on the data we have collected in the past few years in the humanity and health medical groups with Chinese patients treated in Hong Kong with pan-oral DAAs, that is Havani, we compare our data with that published by the target studies in the US, which is the real life. Now, I would like to draw your attention to a few important points. First, our SVR rate is no less or even better than the target studies in the Chinese patients, despite our patients have a higher viral loads, have a higher levels of liver fibrosis in terms of the numbers of cirrhosis, and also poorer liver functions such as higher levels of bilirubins, lower levels of serum albumin, and lower levels of platelets. So these are all the negative predictors of a response to the DAAs for hepatitis C. But despite having these adverse prognostic or predictors to response, our response rate is actually, if not equals, is actually better than those of the Caucasians, suggesting that the Chinese patients might not need treatment of the same durations or intensities as our Caucasian colleagues. It's like as the Caucasians compare with the African Americans. The details needs to be worked out. But one of the observations we made in our group is those patients who come to Hong Kong, some of them, we have measurements of the HCV RNAs in a quite intense manner outside the protocol. This is all regulated in Hong Kong through the ethics committees and approved by the Department of Health in the Hong Kong's authorities. And everything is done according to the GCPs and ICH. We have 367 subjects, Chinese, and we have an opportunity to measure the HCV RNA viral load. These patients are all very keen to have the viral load measured very intensely because they have to pay outside their pockets for very expensive drugs. It is not being reimbursed. So we measure the RNA at baseline, day 2, day 4, week 1, 2, 4, 8, and 12 in 336 patients. And you can see here there's a wide variabilities in the rate of decline of the HCV RNA. So our next logical question is if they respond so rapidly, some of the patients respond rapidly, is it possible for us to really reduce the durations of therapy? Since we are talking about Q boundaries, if these patients, for various reasons, for viral or host factors, they can drive much faster the viral load declines to a certain point, we can stop the therapy. With this in mind, 3 years ago, I had an opportunity to work with one of, I think it's the smartest friends I have ever met, Professor Raymond Shinasi. I actually kidnapped him to Beijing, and we start to have this brainstem thought. And we started a study of 3 weeks response-guided triples, DAAs. At that time, 3 years ago, we are still talking about dual therapies. And so we combined what is being available, one compound from each class, sofosbuvir, LDV, ASV in one group, sofosbuvir, DCV, SMV in another group, and SOF, DCV, and ASV in another group. Well, we choose to study the genotype 1b because we think that they respond better, and this is might be part of the reasons Chinese responds better to DAAs. And also taking into considerations, we have the high prevalence of IL-28, the CC genotypes, up to 80 to 85%. Non-cirrhotic patients, 26. We started them on the triple therapy. And if they respond rapidly in terms of HCV RNA to come to a level of less than 500, we keep them on 3 weeks therapy. Well, at that time, with the mathematical modelings and predictions and power estimations by Alan Parsons, we thought that we might be able to achieve a cure in at least 70% of our subjects if we use this type of protocol. For response guided. Those who cannot achieve less than 500 by the day 2, then we continue for our conventional therapies for 8 weeks with Havani's, or 12 weeks. Now, surprisingly, this is the result. As you can see here, 3 weeks triples DAAs for GT1B non-cirrhotic in Chinese, 100% response. None of them relapse, and we now have long-term follow-up of these patients up to 2 years. They are still seen at our clinics in Beijing, and they remain disease-free, HCV RNA negative, all of them. Now, we are not the only groups. We are not the only groups which advocates shortened durations of therapies. This table enlisted the number of studies which has looked into DAAs therapies of less than 6 weeks with variable success. And I think that there are other factors that we need to understand, but certainly and of great importance is that some of them do respond, and they do not need prolonged therapies of beyond 8 to 12 weeks. One of the factors which is might be of importance is illustrated by the NIH Cotilli groups, which shows that the virological response when the patient is treated for only 4 weeks is dependent on the baseline RAV, the resistant associated variants, which now then plays a role when you shorten the therapy. Unfortunately, there is an absence of genomic data, especially in low-income countries, where there is the barrier is really economical. We have lots of patients suffer from chronic hepatitis C, but these are exactly the countries, the places where we don't have a lot of information on the sequence on the protease, the NS5A and NS5B, and it might be pose difficulties for us to design therapies with short durations of therapy in this group of patients. So this is actually urgently required when we look at the population. Having said that, we have recently also done a cost-effective analysis of response-guided therapies. We took the 3 weeks type of approach, how much money we can save. In our studies, 67% of our patients do achieve HCV RNA less than 500 in 2 days. and we can cure the patients of the virus with only 3 weeks. By doing this, if the cost of the therapies is equivalent to that in the US, we will be able to save 172 billion US dollars for our countries to treat all the chronic hepatitis C. Even if the price of the DAAs dropped by the 10% as currently becomes the scenarios, we can still save the 17.1 billion US dollars for our countries. If we use the generics, we are still saving a lot of money, 1.7 billion. And I think this is something of great importance because in the low-income countries and middle-income countries where the viremic burdens is the most important issues, then we need to really think of better ways, not just to cut all the prices, but whether we can treat less. And for the same amount of pills, we can treat more patients. And I think that this type of concept might be of great importance in developing the public health measures to counteract the problems because we don't have a vaccine to deal with hepatitis C. Government's efforts to negotiate prices of great importance, and also it is important to recognize the chronic hepatitis C patients in places like China and others middle or low income countries. I think this has been figures has been pointed out by one of our previous Australian speakers, Jennifer, and the finger-to-stick capillary whole blood collection assays to give you the quick results of the HCV RN in a very short period of time will be of great importance, not just the antibodies, because then it would help us to deliver the point-to-care the measurements, and I think that to really deal with the problems of chronic hepatitis C and stop the virus from expanding or reduce the related mortality and morbidity, we use the conjoint efforts on various aspects, not just to ask the pharmaceuticals to drop the price because there is a bottom price. We still need to manufacture, and then we also need to diagnose the hepatitis C. We need pan-genotypic therapy so that we can forget about the genotypes and so on and so forth. So there are still a lot of work we need to do in China to really take care of the chronic hepatitis C problems. How about chronic hepatitis B? Well, it sounds that it becomes a less stimulating issues to us. So we have a lot of therapies for chronic hepatitis B, interferons to nucleoside analogs. This is the flow chart of our 10,000 subjects being treated last year in our center in Hong Kong. Interferons and nucleoside analogs. The problems with interferons is that only a few of them has sustained remissions, and a lot of them relapse. And as a result, a lot of our patients are being kept on nucleoside analogs. The good news about this type of therapies, generics is now widely available. Entecavir and tenofovir, the price is really very low. As you can see here, as compared to the Caucasians, it's only around 1 to 5% of the price in the US and Europe. And this helped drastically in taking care of a lot of our patients. Now, the estimate with our national consortiums recently is that we still have 120 million chronic hepatitis B patients, and only 9% of them know they are surface antigen positive, and 8% of them are on the lifelong, the nucleoside or nucleotide analogs. So it is around 1 million subjects is being treated continuously with nucleoside analogs. And therefore, we still need a cure. Because having a cure, we can improve the drug compliance, we can reduce the cost of the therapy, and also we can encourage more patients to be screened because people don't want to be screened, to be found out to be chronic hepatitis B if their options is lifelong therapy. And with unknown long-term side effects and also the cost related to the chronic hepatitis B management. Now, but not least, and I want to bring out another perspective about management of liver diseases in our countries with the use of the non-invasive assessments of liver fibrosis. We have another oral presentation during these meetings which is related, and that is the use of FibroScan and FibroTouch as a screening measures of liver fibrosis in general population. And this is the first of its kind being done in our country, China. We included 291 health check centers, and during the periods of January 2016 to January 2017, this is conducted in the 196 cities, and we have more than 20 million person time a year visit to our health check system. It's huge. And among them, we have solid data on 174,000 subjects with liver fibrosis measurements with these non-invasive measures using FibroScan or FibroTouch. FibroTouch is the generic approved in China as a FibroScan. And you can see here, surprisingly, that the level of fibrosis is not insignificant. In fact, a lot of the patients live unknowingly even with a normal ALT, surface antigen negative. They have advanced liver fibrosis of F3 to 4 or even cirrhosis, around 0.47%. And these patients, we also measure the UAP, which is an assessment of the level of steatosis, and there is a direct correlation. So a lot of these patients, surface antigen negative, anti-HCV negative, with advanced liver fibrosis, they have steatosis. And whether this is NASH or alcohol-related needs to be ascertained. But having said that, we think that we are seeing pictures that apart from hepatitis C and hepatitis B, the steatosis is also causing the chronic liver disease, and this cannot be ignored. To this end, we have set up the Greater China Fatty Liver Consortiums with Aaron Sanyard and also my colleagues in China. So the aim is really to understand the natural histories of NASH, and to collect biological samples and peer liver biopsy samples for the further translational studies to understand the disease so that we can design a further therapy. Last but not least, this is my collaborators in humanity and health medical groups. We now have around 40 people, and we represent the largest private liver centers in the regions. We work with 302 hospitals, where I'm the chair professor over there, and also directors of the translational hepatologies and also the hepatitis centers. They also recently appointed me to be the co-director of the liver transplant programs. And I also work with the Nanfang hospitals and my international collaborators with Ray Shinasi and also our molecular pathologists. We have built up the Humanity and Health Research Centers, which is a branch of our medical group, headed by Professor Joanne Cowbridge, who is the one who set up the clinical trials settings in Hong Kong for over 20 years. He has resigned from the universities and now he's running as a director. So we have built up the research centers to conduct all the clinical trials based on our populations collected from mainland China, and the site is Hong Kong. So this would allow us to bypass a lot of the registrations for the clinical trials processing in mainland China, and to have access to Chinese with liver diseases so that we can speed up our process to understand how we dealt with the problems. And this is my last slide, Chairman. Ladies and gentlemen, we, the medical groups, look forward to the future collaborations with pharmaceuticals and also all the academics, and we hope that we can improve our management on liver diseases in our Chinese populations. Thank you very much.